Thank you all for joining this. I'm sure you all have other things you could be doing, but instead you've chosen to take the time to come to this webinar into a really crucial issue in social care research. So this is part of the NIHR School for Social Care Research Capacity Building Webinar series. They've been a fantastic series and there are more to come. Really addressing, I think, fundamental issues for social care researchers. From some of the people who are absolutely the best in the business to talk through these issues. So today we have Dr. Anne-Marie Towers, who's a reader in social care in the Centre for Health Services Studies at the University of Kent, and she's going to be talking through about the inclusion of people who cannot self-report in research in social care. Dr. Towers is going to talk for about 40-45 minutes, and then there'll be some time for questions at the end. So where we will unmute you if you have a particular question to ask. As we go, there is a chat function, so you can put any questions in the chat function. And although multitasking is beyond me, unitasking is sometimes beyond me at the moment, but I'll try and look through that chat function as best I can to pick out some questions towards the end. So if you keep yourselves on mute, I think it's nice for those of you who want to keep your video on, because it gives Dr. Towers people to talk to, which I think is useful. So I think that's all I've got to say for now. So I'll hand over to Anne-Marie Towers.
Thank you, Chris. Hi, everybody. Right, I'm going to try and screen share. If the reception is bad, then honestly, I don't mind if people want to turn cameras off, because I know it can be really difficult. Hopefully you can hear me okay. Right, I'm just going to try and share this with you. Hopefully you can now see my slides. Is that looking all right to everybody? Yeah. Okay, great. So so today's session is thinking about what we can do as researchers when things like conventional self-report, as we would usually use, aren't really suitable or are going to be really challenging or difficult for some of the people we're trying to work with and recruit to our research. Obviously, just as a little bit of an overview, we know that gathering the views of public, patients and service users is a fundamental aim of social research, not just social care research, all health and social research. The experience, satisfaction and quality of life of service users has become really important in terms of indicators of service quality, and we're under increasing, not just as researchers, but as practitioners and people working within services, under increasing pressure to find alternative ways to be able to collect and measure people's views. As you will all know, most methods, most conventional methods, rely on the person being able to self-report. But this is going to be challenging for a lot of our social care users these days, and that means that many of them are being placed at risk of exclusion from having their voices heard. Now, when we think about things like inclusion and exclusion from research and evaluations, some of those issues relate to much broader concepts and much broader issues in society. For example, access. So how do we actually identify the right people, and how do we find them to be able to recruit them to the research in the first place? So I've decided not to focus on that for today. My focus is going to be on how we enable inclusion, assuming we can recruit them. So getting over that first hurdle, which I know is important, particularly in things like homelessness research. But I'm going to assume that you've got access to the people and that you've recruited them. And now what we're actually focusing on how do we include their voices in the research as best we can. So to begin with, I want to have a look at the kind of conventional self-report methods. So questionnaires, obviously a quantitative methodology, something that everybody is probably already very familiar with, has some huge advantages. It reaches large numbers of people. You can administer it postally, you can do online. Obviously in this day and age, that's going to be a really popular method. In terms of consent, it's usually pretty straightforward, because there's you provide information at the start of the survey, and if the person decides to complete it and return the questionnaire, consent is given. And of course, although they're very complex to design and require a lot of expertise to get right, when it comes to the administration, they're relatively inexpensive compared to other methods. However, there's clearly a lot of barriers to inclusion with this methodology. So the first one being consent. It's really difficult to know when you're administering a survey whether the person responding actually understood the aims of the survey, how you're going to store and use their data, and even being 100% sure that the right person has filled it out. So there's immediately some kind of issues with certain user groups as to being really positive and really sure and confident, I guess, going forwards, that the person that you think you're consenting to the survey really is giving informed consent. Then there's comprehension. So do they understand the questions and the response options? Are they able to choose the one that best represents how they feel? There's things like mode, layout, format. So a lot of times people, especially with cognitive impairment, can find this very confusing. So you get a lot of questions, you get tick boxes. Sometimes I'm sure you've all seen these, tables with little dots, and you've got a Likert scale. Even if you don't have any needs, you can find yourself having to go across like this and think, right, have I ticked the right box for the right option? How many times have you done some sort of survey online on Qualtrics or something like that, and it said to you, oh, you've ticked, you're not allowed to tick 2 response options in the same row. You didn't even know you'd done it. So that these things are quite complicated and quite difficult for people to do. Physical and sensory barriers. So some people more than capable of answering all your questions in a questionnaire, but actually they would need some tweaks or changes to that format that you deliver it in. For example, they may need Braille. They may need somebody just to be their scribe because they have difficulty holding a pen, for example, or operating a keyboard. Then there's things like submitting the responses, a little bit easier if they're online and they've been able to access some sort of digital format of the questionnaire. But if you think about postal questionnaires, it can be delivered through a doormat. Someone might be able to complete it themselves, even pop it back in an envelope. But can they physically get out of the house and arrange for it to be posted and delivered back to you? So even for the most simple stages of completing and submitting a questionnaire, you can see straight away we start to run into some really serious pragmatic problems for some people. So the solution to that is often to think about, okay, well, we know that some people are going to find that difficult. So could we maybe bolster the sample by doing some structured interviews? So essentially the same questionnaire, but through an interview or interview format, which of course could be face-to-face. In COVID times is more likely to be online in this kind of format, or potentially over the telephone. Consent is often in advance and then again confirmed on the day. And the advantage of this is that the interviewer can, of course, support understanding. They can provide that clarification. They can prompt. So you've got some level of support there. And obviously with things like scribing, you're taking away the responsibility being placed on the respondent, and it's being placed on the interviewer instead, who can do the tick boxing and can write notes and also audio record sometimes the person's responses for later analysis. So this is a really good option for kind of bolstering self-report alongside a kind of self-completion questionnaire. And it's very good for people who require practical assistance, but maybe don't have someone like an informal carer, someone living with them who can help them in that sort of practical way. However, it's still not without its challenges. So even with all that kind of practical assistance and help, you've still got to think about comprehension and manageability. So as we said before, standard question wording and response options can still be too difficult for people to understand. Just because you're reading it out and maybe you've got a show card and maybe you can provide some explanation and maybe some prompting, that still won't be enough for some people to be able to understand and give a meaningful response. Manageability, here what I mean by manageability is things like, is it too long? Is it too structured? Some people will be able to talk to you quite openly about their lives and their experiences, but if you give them a Likert scale, or if you tell them, we've got these 4 options, I want you to choose one, it's just too difficult. They can't, they will flounder, and you have to query how meaningful some of those responses will be. And I'm sure a lot of people watching today will have had that experience where they've maybe asked someone to answer a very structured question, and even when they've picked an option, you're doubting whether they really chose the option that was right for them, or whether they really understood what they were responding to. So some people just prefer more open questions. Okay, so what are we, I suppose, what are we actually trying to achieve when we're thinking about these barriers to inclusion? Essentially, what we want is for research participation to be manageable for people, comprehensible for people, and meaningful for people. So that's our goal. And if you look right in the center of all those circles, you've got this kind of little bit where they all overlap, and that's what we're all aiming for, is to meet all those goals. But of course, what that looks like is going to be very different depending on the person you're interviewing's needs, or the person you're recruiting to your research's needs. It's not going to be one size fits all. So let's think about what factors we might have to consider. So what does manageable, meaningful, and comprehensible look like for somebody? These are just some examples. So for it to be meaningful for me, I would need to be able to tell you it in my own words. For someone else, it's going to be, to be manageable, I need lots of breaks, or I need someone to write down my responses for me. I can say what I want, I can maybe even choose it, but I can't do the scribing. For other people, it might be as basic as you need to give them 2 options, and using eye gaze, they can choose which one they want. Now, that's quite limiting from a researcher perspective about what kind of questions you can ask. However, it can be a way of making an interaction or gathering someone's views meaningful for that person, and giving them some kind of voice in their own data. And then if you look down towards the bottom of the slide, I've put it, I need someone to answer for me. And ultimately, that would be where we have to rely on a proxy to give a response. So I'm going to talk a little bit about those. Okay. So it depends on the person and their needs. And obviously, as researchers, you can't do everything for everyone. So what I would recommend is that you think about in advance your sample, which service user population maybe that you are targeting, and what their likely needs and barriers to inclusion might be. And then think about how you might be able to work through and deal with some of these barriers to inclusion. I've put here, it can be limited by validated instruments and tools. Obviously, with quantitative research, and particularly questionnaires and structured interviews, we all want to be using tools which have been validated and tested, and they're rigorous and they're robust. That's great, but it can come with its own challenges, because oftentimes those types of questionnaires also have quite stringent rules and regulations around how you can adapt to them. Even as simply as, can I change the layout, make the spacing bigger, make the text bigger, move something that's 2 questions on one page to 1 question on one page. Maybe you think that the ordering of the question needs slightly altering for this population for some reason, because they need to start with something concrete and work up to more abstract principles, and actually the questionnaire isn't structured like that. So there are all kinds of reasons why you might not be able to do the things you want to do, and that's why I think it's really important that we do studies such as content validity studies and things like that, that actually look at different modes of administration with some of these questionnaires and test them with the populations of interest, so that we can have validated scales that have been adapted to meet the needs of the people we're trying to include in the research. So I thought, rather than just sort of go through all the various possibilities, some of which I won't have tried myself, I would draw on some of our own experiences. The work that we've done around the Adult Social Care Outcomes Toolkit, where we've done quite a lot of work to try and increase inclusion and participation. So just before I explain that, I'm aware not everyone will know. So the ASCOT is designed to measure something called social care related quality of life. There are 8 domains of social care related quality of life, different aspects of the person's life that can be impacted by social care. It's a structured, preference weighted questionnaire that was designed for quantitative analysis, which is why I think it's quite a useful example for today's session. And it was developed and tested with older social care users in its original format. And that was a self-completion questionnaire and a structured interview. And the people that we tested it with in those early days, they were home care users, and they were all people who had capacity and could self-report. and it was validated with that population in mind. So these are people who would be able to complete, say, the adult social care user experience surveys, or at the very least undertake it with support, maybe through a telephone interview. So I'll just give you an example of what that standard questionnaire format looks like, and then you'll be able to understand how we've adapted it. So it's a 4-level questionnaire, by which I mean that every domain has a question followed by 4 response options. So this example question from the control over daily life domain: which of the following statements best describes how much control you have over your daily life? A little bit of an explanation for them. This is designed for self-completion, and then they can tick one of those 4 response options, ranging from the best to the worst. So what we found quite early on was that this worked well for the group that we tested it with, but for a lot of our service users, that they were going to need some adaptation. So the first group that we worked with were adults with intellectual disabilities and autism, and this work was undertaken as part of Policy Research Unit Quaru, and led by my colleague James Cales. And Agnes Turnpenny, who worked at the Tizard Centre, who obviously specialise in people with learning disabilities. And we brought together a working group of adults with intellectual disabilities and autism. And we also had a designer, and we worked through to simplify that wording that I've just shown you, and also to create images and symbols that could be used to support understanding. In between the working group getting together to make these changes, there was cognitive interviewing with other people with autism and intellectual disabilities. And that really helped because it really fed back what worked and what didn't work in the changes that we were making. And then the group would reconvene, discuss those changes, the feedback from the cognitive interviews, and make another round of changes, and we would go again. And so there were several stages like that of iterative changes and testing. And then since then, the measure has been included in a much larger pilot survey where it was validated, and I've got references at the end for people around its the validity and performance of the scale in this adapted format. And I think very importantly, we followed the COSMIN standards of patient-reported outcome measures. And that's something that with any of these kinds of changes, you want to be seeing people doing, so that we know that the changes aren't fundamentally changing the meaning of the questionnaire or how people are responding. So here's an example of the Ascot Easy Read. I've kept the control over daily life question here, so it's comparable. So you can see that it starts with, at the front, so there'll be 1 question per page. And at the top, you've got an image. And those were the images that were designed with the working group and then piloted both through the cognitive testing and the validity survey. And it's to get people thinking about the kind of choices that they might make in their daily lives. You've got some simplified text, and you can see straight away there's more space. The sentences are shorter, they're easier, they're just easier to read. And then even the response options were slightly tweaked. And then to support understanding even further, we tried out these little faces down the side. And believe me, this was one of the bits that took the longest, was getting these faces right for people. So, so you can see, hopefully you can see how much of a difference that would make to somebody's understanding. But because we've done all the validity checking and because we did the cognitive interviews, we can feel quite confident that we've kept the essential concepts the same. I've put don't forget the instructions. So if you're thinking about creating an easy read version of a questionnaire or something like that, then one thing that can be easily forgotten is the instructions alongside it. So it's all very well and good if you're going to send somebody a questionnaire that's with all that care and attention taken into the spacing and the layout and the format and the wording. But if you forget to also do that with your instructions, the chances of your questionnaire being returned are really slim. So we have a few pages like this, which is also developed with the working group and experts who work with people with intellectual disabilities and autism, so that we could try and make this as manageable for people as possible. So even with all those adaptations, we sometimes find that's still not enough. So some people will benefit from that easy read format and the simplified language, but they need additional help in terms of kind of scaffolding to help them stay on track, and maybe even just to give them a little bit of confidence that they're doing the right thing. And so a self-completion questionnaire can be administered in a kind of supported interview format. So you're bringing together those conventional methods, but in a kind of easy read format and in a more scaffolding interview. So we did some work, James and I did some work with Dr. Lynn Phillipson, who's based in the University of Wollongong in Australia. She'd spent some time with us over here in the UK. She became familiar with the ASCOT, and she's actually a dementia fellow over there. She was really interested in, could we use this ASCOT Easy Read format with older adults who struggle to do that sort of standard self-completion questionnaire. And so what she did was she first of all sent out the standard questionnaire so that we could see who struggled with it and identify them that way, because it's not as straightforward as saying, if you've got dementia, you can't do it, or if you're this sort of person, you can't do it, because everybody's an individual and everyone's different. So once we'd identified those people who would really struggle with that kind of standard format, she then sent out the ASCOT Easy Read that I've just shown you instead. And she also offered to come and help people fill it out. What was interesting was that most people wanted her to come and help fill it out. And so she sat there and administered the Easy Read questionnaire, but as an interview. And what she found by doing this was that just as straightforward, I'm going to read a question, show you the response options, oftentimes still wasn't enough. What we found was that if you followed a kind of more structured approach, very similar to how you would do it if you were doing cognitive testing, so you call it a staggered reveal method, what we found was that this really helped people stay on track, focus, and give meaningful responses. So we started by exposing only the image. So if you think back to that Easy Read, we just showed the picture at the top and got them talking about it. Maybe the name of the domain, like talking about choice and control. Here's a picture. What do you think about that? And then you would say, and this is the question, you show the question. Do you understand the question? And they might even say a few words. Oh, yes, well, I feel like this, I feel like that. And then you say, okay, let's have a look now at the response options. Which one of these, given what you've just told me, do you think best describes how you feel? And you show them those Easy Read response options. And what we found was that that was the most facilitative, and it enabled people who would have been previously excluded. They would have been people who wouldn't have returned that questionnaire, possibly wouldn't have even returned the Easy Read questionnaires. They would have been excluded from any kind of evaluation using that methodology, were able to provide responses using that kind of scaffolded interview technique. So what we're doing at the moment, because that was only a very small kind of exploratory study, what we're doing at the moment is we've applied for funding here in the UK to do a content validity study using that Easy Read measure as our basis, and we will replicate the work, if we get the funding, that we did with the Easy Read development work, in that we will get together a group of older adults who are social care users, and we will adapt some of those images to make them more friendly and more relevant to the people that we're talking to, so the older adults instead. And we will go through and check that the layout works for them. And then we will do a little some cognitive testing and improve it even more, with a view to having an Easy Read version, which is for older adults who have trouble with self-completion. And what we anticipate is that although some will be enabled to participate just through the Easy Read format, others will require this scaffolding kind of interview approach. So hopefully we will be able to really test that and offer some kind of more insight into that in the future. So having said all of that, there is still a group of people, particularly those living in care homes, who even with all of that support and adaptation are still going to struggle to have comprehensible, meaningful and manageable participation in research. And here I'm going to focus mostly on my own experience, which is with older care home residents. And what we've found here is that most older care home residents these days, particularly those who are publicly funded, are not able to take part in this kind of very structured interviews without a lot of additional support. They have multiple comorbidities, physical, sensory and cognitive impairments, all of which can make even what you might think of as a very straightforward interview very complex actually to achieve. So we found that a single method of data collection is not suitable for this population. You will always get some people who in some facilities who are pretty much physically frail but cognitively really still with it, and they can self-report quite with a little bit of minimal support. But very many will not be able to do this, and they will be able to have a conversation with you about aspects of their lives, but not a full interview. They will need it to be quite short. They will maybe need it to be centered around quite concrete concepts. For example, we often will ask them about what they think about food and drink whilst they're eating, or when they've just literally finished eating, so shortly after lunch, so that it's something quite concrete and something that's really fresh in their minds. Some people cannot tell you how they feel at all because they're bedridden or they've lost the ability now to verbally communicate or to understand what you're asking of them. So how do we collect some kind of comparable information that we can maybe use in some kind of quantitative analysis with this population? What we've done with ASCOT is we've developed a mixed methods toolkit that's able to gather evidence in different ways, and that evidence informs a field worker or researcher rating, which is where we get that comparability. So the ASCOT Care Homes Toolkit uses all those different methods. You have a structured observational period where you would undertake observations of 5 to 6 residents over a 2-hour period in the communal areas, often leading up to and including a meal time. During that 2-hour period, you'd rotate around the residents that you're observing who are included in your sample and make notes relating to your different aspects of their social care and quality of life, those different domains. And what you're largely doing here is you're looking for visual cues about their lived experience. You're looking to make notes about different aspects of their quality of life according to those domains, which of course I'm thinking about it for ASCOT, but would be equally applicable to any topic or any outcome that you're wanting to measure. And you're using that as a kind of way of gathering evidence about what that person's life is like in that respect, but also to inform maybe follow-up questions and prompts that you might ask of residents and also of proxies later on in the day. So the next thing that we would do is we would interview the resident. Now we always do this, but the way in which those interviews go ahead will vary enormously depending on the needs and abilities of the person we're talking to. So as I said, for some people that will be quite a structured interview, but for others it will be a little chat, like sometimes sitting next to them while they're having a tea and biscuit in the afternoon and saying, hi, I've come here to chat to you today. How are you? I'm fine. What do you think of it here? Yeah, I noticed you did this morning. How did that go? So it is very conversational. But what that can be still very useful to do is it can plug gaps in some of the things you observed. So it can help you clarify things that you've seen and you want to gather their views on. It can also be really useful if you've noticed there's an issue for a person in a particular aspect of their life and you really want to get their perspective on that because you're feeling that from what you've seen or what you've heard from proxies, this is a particularly important thing to that person. So coming back to making things manageable, meaningful and comprehensible. If you can't get all the information from the person, then try and get the information that's most meaningful for that person. In terms of proxy perspectives, we always gather a staff interview, which is straightforward, them giving their view of what the person's life is like. And wherever possible, we also speak to family members, but that can be challenging. So I thought it might be interesting for you to reflect on the impact that methodology has on inclusion in care homes. So I'm drawing on, we've merged data from 2 findings here. The Measuring and Improving Care Home Quality Study, which is just finished, funded by HSCR. The final report, we've just had the peer review comments back, so it's not published yet. And the Measuring Outcomes of Care Home Study, which was an SSCR funded study, and there's references for that at the end. We've brought both those data sets together and we had a look to see what data we managed to collect using that kind of mixed methods toolkit on each of the residents in both studies. And we looked at how many of those residents would have been excluded had we not used that mixed methods approach. And I found it really interesting, actually. So across the 2 studies, we had 475 residents. they were living in nursing and residential home, about 50% had a diagnosis of dementia. And I think that's quite important, because it's really important to remember that having dementia isn't always the best indicator. Whether or not you've got a diagnosis isn't always the best indicator of whether or not they're going to be able to self-report or be included in different sort of research methods. It varies so much according to the individual's needs and the type of dementia that they have. So because we use mixed methods and we evidence gather and we use that to make a rating, the beauty of that approach meant that we had no missing data. In other words, we had ASCOT scores for everyone, because as researchers, we're the ones making those final ratings. And we use the evidence that we have available to us to make those ratings. If we had relied only on resident interviews, then we would have had almost entirely missing data. So the easiest domain for residents to answer out of the ASCOT domains was what we call the accommodation domain, which is a straightforward, is my accommodation is clean and comfortable. So as you can imagine, that's a very concrete concept for people to answer. That you can be in their bedroom talking to them about their bedroom and say, what do you think of it here, and ask the question, and they're looking around and they can tell you about it. It's quite easy. Whereas some of them are much more difficult. They're much more abstract. Think back to that control over daily life question. How much control do you have over your daily life? You're weighing up a lot of things to make that decision, and that one has quite a lot of missing data if we rely only on resident interviews. But interestingly, only 31% or nearly 32% across both samples could complete even that accommodation question. So I think that really demonstrates the need for more flexible methodologies in care homes. And I've put here, you need every answer to get a score. So this is the other slight complexity with the ASCOT measure, is that although we might have had 30% for that domain, if we don't have a rating, if you like, for each of those 8 ASCOT domains, you're not going to get an overall score. So it was probably more like 10% that we would have actually ended up getting an official ASCOT score for quantitative analysis at the end. Staff interviews were much, much better. So we have 91 to 94% response rates at that domain level. But that, of course, is giving a proxy perspective rather than, it's not the same as getting a person's own perspective. And we all know that although proxy perspectives are sometimes necessary, they are different from the person's own view. We only managed to get family perspectives for around 10% of the sample. And this is possibly indicative of our recruitment. So, it's quite challenging in care homes to engage family members. And because we're doing this larger data collection, quite quantitative data collection, maybe we're not spending as much time recruiting family members as if we were doing maybe a smaller qualitative study. But nonetheless, I think it's important to actually share that it can be really difficult to get family members along for these interviews and to give their perspectives. So this data, these findings from these 2 studies are included in this NIHR Health Service and Delivery report for the MyCare study, which hopefully will be published within the next few months. Okay, so thinking now just along the lines to proxy report. So we've talked a little bit there about getting staff and family members to give their views in that mixed methods approach. For some people, self-report isn't possible. Certainly not if you're going to be asking more complex questions, such as a structured questionnaire. So proxy report can offer a pragmatic alternative, and I'm not saying that it shouldn't be used, because I think it's still better to use that than exclude the person altogether. And particularly in people's own homes, that might be your choice. You either find an adaptive form of communication and try and include them that way, and if all else fails, then falling back on a proxy is going to be a lot better than excluding their experience and their voice altogether. There are 2 types of proxy. There's proxy patient, where the person tries to give their view of what the patient or the service user thinks. And there's proxy, which is my view. This is what I think their quality of life is like, or this is what I think their health is like. What we've found is that it can be really helpful to measure both, recognizing that they are distinct. And this is the approach that we took when we developed the ASCOT proxy measure. So we've actually got a new study that's being undertaken at the moment, which is validating the proxy measure with the informal carers of people with dementia for exactly this reason. That's still midway, so we'll be finishing in 2021. If I just show you an example of the proxy questionnaire for the ASCOT, this is the way that we've dealt with it. So again, I've looked at control over daily life for you. So this question is about how much control the person you are representing has over his or her daily life. A little bit of an explanation. And then they've put the person I'm representing has, and we've got here my opinion and how I think the person would answer. And it's really interesting to get both perspectives, because certainly before we did this systematically, we all noticed that when we got proxy perspectives, it could sometimes swing quite a lot between them giving you the person's view and then really they can't help it sometimes that they want to give their own view. And so what's nice about having the two alongside is that it gives space for the person to make that distinction cognitively themselves. It's nice for them to be able to say, well, they'd say, da, 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 da. However, I know that's not my perception of it. This is what I think is happening in their lives. And from an analysis point of view, having both perspectives can also be really interesting, because you would expect maybe that they would be related to different things. For example, the carer's view may be related quite highly to things like carer burden, hours of care that they're providing. They may be thinking, I would like my mum, dad, whatever, to have more care, and this is impacting on how they feel about how well that person's coping. There's all kinds of things going on when somebody's answering on behalf of somebody else, and then giving them space to say how I think this person would answer. We found it was easier for them to do that once they'd got out of the way how they felt. So it's just one option. It's not the only way, but it's something that we found really useful. And I'll be really interested in the results of my colleague Stacey Rand's study, which is looking at this tool and validating this tool with the informal carers of people with dementia. Okay, so that's a real whistle-stop tour, but trying to look at some of the methods that we can use to make research participation manageable, meaningful and comprehensible. Obviously, I've focused on ASCOT with a view to undertaking quantitative analysis, because I think that's oftentimes where we really struggle, is where we, in an ideal world, we'd like to collect lots of data in a quantitative way for that kind of analysis, but the methods are really problematic for us. So that's partly why I focused on that. And that's certainly the challenges that we've had to overcome with the ASCOT work. But obviously what I haven't touched on here, but it would almost be another session, is all the qualitative ways that you could collect people's views and include them in research. But obviously that's a completely different research question that you would be answering. But there are things such as the qualitative interviewing that a lot of people, I touched on it a little bit when I talked about the mixed methods approach. So you can do qualitative interviews with care home residents very often. Discourse analysis, so by observing or taking part in audio recording a conversation and then doing some analysis to unpick the underpinnings of what's going on, either between a carer and the cared for person, or even between you as the interviewer and the person responding. There's things like ethnographic methods, and of course things like action research, where you really embed yourself in a service setting to really try and understand what's going on in that setting and for those people. So I realised that I've neglected those, but I think it would have been a bit unmanageable probably to get it all done in one session. But I just wanted to flag that there are these qualitative methods that you can use as well. I've talked a lot about some of the work that we've done with ASCOT. So I've already given a link to the website, but there's also some references here that you can take a look at if you're interested in any of the kind of adaptations that we've done, and also if you're interested in the validity of those adaptations. And as you'll see, I've spoken on behalf of lots of colleagues here. This is not all my work by any stretch, and so I just wanted to recognise all their input into this, and they're the experts on some of these other tools. Finally, disclaimer that these are my views and not those of any of the funders. And contact details for those of you who might want to follow up on today's session. Thank you.
That's fantastic. Thank you, Emery. I think that was a really good summary of principles and methods. And as you see, you've suggested a topic for another webinar in the future as well. So there you go, added value. So we've got some good time for questions. One's in the chat already, so I'll start with that. This is from Georgios. Says, thanks, Anne-Marie. Any thoughts on using those tools in a pandemic context? For example, how do you do a supported interview whilst there are physical distancing measures in place? Is going online an option? Very topical question. Thank you, Georgios.
Yeah, well, the short answer is I don't know because I've not tried it. The long answer is I think it should be possible if the person that you are interviewing has maybe someone to provide them with the support that they can access a setup like Zoom or Teams or whatever platform you want to use. I would encourage video enabled interviewing rather than just sound, because so much communication is non-verbal, and so being able to look the person in the eyes, pacing is so much easier, isn't it, when you can see the person, and scaffolding should be possible. You would need to put quite a lot of thought into your screen sharing. I think off the top of my head, if I was going to do it, I would try and do it over a platform like this, and I would try and screen share so that I would show the image first of all and ask them a very open question, and then maybe show the question stem and get them talking openly in a qualitative way, and then put up the 4 response options and then say which one do you think most is. So I think you could do it, and it would be really interesting to try, but I haven't tried it myself.
Great, thank you. Quite a few people in the chat are asking if you're happy to share the slides from the webinar. That's brilliant. So we'll make sure that happens. We have a question from Kate Gridley, saying, thanks, Anne-Marie. I'm really interested in the scaffolded method you described. How rigid or flexible were you in terms of standardization? E.g., did the interviewer explain questions in their own words, or did they use pre-prepared explanations?
No, so it wasn't as systematic because it was more of a suck it and see, if I'm honest. So what we initially anticipated was that the easy read itself would help self-completion, and then maybe it would be administered in a very kind of conventional interview format for those who didn't. What we learned very quickly was that the staggered reveal method itself, so it's a staggered reveal method, comes from cognitive interviewing, but if I treat it as scaffolding understanding, then what we found was we sort of learned it on the job by accident. So we started, I think it was like, okay, the interviewer was very talented and basically realized the person was struggling, and so started small and said, let's just look at the picture, shall we? So it was a kind of fortunate accident, really, and the aim of this study that we've applied for funding for will be to take that on in a more systematic way, and then we'd be able to maybe have some guidance that would be really useful to others. So yeah, it was a fortunate accident, but I think my gut feeling, having done a lot of interviews with people with varying needs, is that I think this could be a really nice way of doing these kinds of interviews, and we could maybe share that learning with others in the future and apply it in a more systematic way going forwards.
Thank you. I'm really interested in it, and I wondered, have you written anything up from that? I know it was kind of exploratory, kind of learning job.
So the paper on the references that's led by Lynn Phillipson, it's on the reference list that I just gave. She outlined some of that in that paper. James and I were co-authors because all the work was done in Australia. So we were kind of just consulting from the UK on that study. But because it's ASCOT, that's why we were involved. But I think, there's another paper in submission as well that we're talking about it in a bit more depth. That's still in submission. But I'm really, really hopeful that we'll get the funding and we can really write about it in more depth. Yeah,
definitely.
But have a go, see if it works for you.
Thank you. I have another question on the chat. Just to say before I get to that, if you want to raise your hand and actually ask a question, if you click on the participants button on the left, there's a little blue raise hand which you here we go. Question from Rebecca Lepping. A wonderful presentation. There's quite a few saying that. Thank you. I'm curious how similar or dissimilar the researcher observational ASCOT scores were to the proxy report.
Oh, yes. That's a really good question. So we have actually looked at that, and I can't remember off the top of my head because it's a 50,000 word report and that's one section of it. But there are differences. So we've looked at the difference between a staff rating and our rating and the residents' ratings. So we've looked at how they all compare with one another, and we found that some domains, so there was most agreement over what we would call the basic domains. So this is things like safety, food and drink, accommodation, and personal cleanliness and comfort. So around those domains, the agreement level is higher. Where you get the bigger discrepancies was what we call the higher order domain. So this is like psychological well-being, so moving into things like control over daily life, social participation, and occupation, which is sort of engagement in activities for most older adults in care homes, and then and also dignity, so how the person's treated and how that makes them feel. What we tend to find is that staff will overestimate quality of life in those higher order domains. Family members often underestimate quality of life in those higher order domains, and the resident often, if they can tell us something, is somewhere really in the middle. The way that we resolve it in ASCOT, when you use this mixed methods approach, is that we have a hierarchy of evidence. So we make it as systematic as possible so that any ratings are comparable, and we can prove how we got to those ratings. So where the person is able to respond and give their own view, that takes precedence, and that's the rating that we will use, all the way through to, you know, the person hasn't been able to be interviewed at all, but we've got a staff rating and we've got our observations. And in those cases, we would take lived experience evidence over a proxy rating if we were sure what we were seeing was quite reliable. And we do spend a lot of time in the homes to collect that data. So anyone who's interested in that approach, I'm really sorry, but you do have to come on training. But hopefully you can see that it's not like a week, it's a couple of days, but it's quite complicated. And one of the dangers with that mixed method approach is that you won't get comparable ratings. People will go off and do their own thing, and we want it to be systematic. So that's why we offer training on that. But please don't ask for it at the moment because of the pandemic. And it's very difficult to do that kind of training remotely.
That's great, thank you. So important point from Bridget Penhale on the flexibility, saying having some flexibility around wording and explanations might be preferable, but clearly needs testing. Then there's a question from Howard Allen, which might be fairly straightforward for you to answer. Thanks, Anne-Marie. I would like to conduct some research on personal budgets and direct payments for social care. It seems to me that ASCOT is relevant as a framework. Does that sound correct, or am I missing something?
That is correct.
There you go. I thought it might be straightforward. And next question is from Roel. Thank you, Anne-Marie. We found that assisting people with assessment, for instance, by performing as a structured interview, possibly introduces some side effects. Especially with sensitive topics, we found that people tend to be less critical towards carers and services, for example. Do you have experience on this topic?
No. This is a challenge, though, isn't it? I think when you're talking about anything, I think it's something that we just have to acknowledge when we're doing this kind of work. I'm not really sure there's an easy answer to this, because equally you get it if the person is being assisted by a care worker or assisted by an informal carer to complete a questionnaire. Obviously anyone who's doing questionnaire research will know to have a section at the end saying, did you receive help with this questionnaire and what kind of help you received, and we can control for that to a degree within the analysis. But understanding some of those biases that brings in is really difficult, I think. When we carry out research where we are explicitly looking at the impact of care on people's lives, we try and do it out of earshot of staff, and where that people feel less pressure to always be positive, because we know, particularly in that generation, there's a tendency to say everything's fine. Yeah, that can be quite difficult. One of the things that we often do, one of the reasons that we say do the observation before you do the interviews in that mixed methods approach, is because it gives us sometimes almost like conversation starters. So we can say, oh, I was, you may have seen me earlier, you know, I was sitting when you were having lunch, I noticed this, or I noticed you did this activity. What did you feel about that? Or I noticed they cut that short. Does that happen very often? How do you feel about that? So like sometimes that opens up opportunities for people to speak more openly, but in a kind of assessment situation, it's difficult, isn't it? I wouldn't know what to suggest really, other than to acknowledge that this is one of the problems.
That's great, thank you. Excellent question. Question from Adila. Thanks, Anne, for the great presentation as always. Just wondering if you have an ASCOT-CH easy read version.
No, but if we do this next study that I was telling you about, the view would be that it could be integrated into that care homes work, because it will be being tested with older social care users who cannot self-report. So although we would anticipate doing that testing with older adults in their own homes, because at the moment we have no kind of alternative way of getting at those people. You can't stand in their lounge and do an observation, for example, and think it just doesn't work. So they're the priority in terms of giving them a voice. But I would anticipate that an easy read version that's been tested with older home care users who can't self-report would be an excellent place to start also trying that out with some people living in care homes. So that really, that study is the one that I'm really hoping that we get.
That's great, thank you. I can't see any blue raised hands, and I can't see any more chat questions for now. Oh, Ruth Bartlett is waving. Can you unmute yourself to ask your question?
Question. Thanks very much, Anne-Marie. That's really clear and informative. I just wondered how important it is to be sitting down during the process. I've done quite a lot of walking or going along interviews with people with dementia, and I know other researchers are increasingly recognising the importance of, you know, mobility and going along with people during interviews. So I just wondered if you could perhaps just tell us whether you could see that working.
Scaffolding one will be hard to do walking, but so we do a lot of we interview people in really any way they want to be interviewed. Anything that we can do, we do. So yeah, we've walked along corridors. I think I've sat on the floor. You know, sat on beds, stood up, and just done it standing up but not moving. So I think I absolutely see your point. I think, you know, the idea of doing, I don't think you want to be restricted. There's, as far as I'm concerned, it's about inclusion. And so our job is to try and how can we make this interview manageable for this person? And a lot of that will come down to the skills of the interviewer and their willingness to be flexible on the day. So yeah, I agree with you, Ruth, that I've done lots of walking interviews and they can be brilliant. And actually, if you're asking somebody about their lived experience, walking around the place they live can actually be an environmental prompt, you know. So it can be more effective than just sitting still. But the scaffolding one, I don't know how that would work, because I imagine that would be, just from a very practical point of view, it'd be quite difficult to do. But who knows? We can. I mean, I think you should try these things, you know, and see what works. We haven't tried it.
Thanks.
That's great, thank you. So it's nearly 2 o'clock, but there's one last question on the chat from Susan Haverkamp. So I'll read this out. We're developing a self-report interview on mental health for adults with intellectual disabilities. We're very interested in the similarity between self-report and proxy perspectives. I'll be very interested in your findings about higher order domains. Is there more that you can share about this? Yeah.
So if you have a look at the reference I gave you on the proxy report, there's already some work out there on this. The emerging stuff that is in press at the moment relates to its use in care homes, but there's already references that you can have a look at, and I've included them on the slide. And then the forthcoming work that's still being collected relates to informal carers of people with dementia, and that will also look at the validity of that proxy approach for that population.
Fantastic, thank you. So it's nearly 2 o'clock. thank you all for coming along to this webinar. The questions and the comments have been really fantastic. So it's great that so many of you have turned up and hopefully got something from this. Thanks to NIHR School for NIHR School for Social Care Research even for organising this series, and there's look out for more because they'll be equally fantastic. And most of all, thank you to Anne-Marie Towers for a really thorough and stimulating presentation on a fundamental social care research issue. Thank you.